Good afternoon. Welcome to the Symposium on Gastroenterology. So there are three resource persons. First, I would like to call upon Dr. Professor Anurag Dasanayaka, Professor in Pharmacology, Faculty of Medicine, University of Kelaniya. Professor Dasanayaka will be delivering the lecture on NASH, an update. Over to you, Dr. Professor Dasanayaka.
Good afternoon, ladies and gentlemen. First, I would like to thank the President and the Council of the College of Physicians for inviting me to give this update on NASH. After that brilliant session, unfortunately, we have to come back to the reality and discuss some real issues as well. NASH is a complicated metabolic liver illness, and it's the progressive form of NAFLD or the fatty liver, which leads to fibrosis, cirrhosis, and hepatocellular carcinoma over many years, and consists about 10% of patients with fatty liver. So if there's a progressive form, there's a non-progressive form, the simple steatosis. Is it safe to have that? Answer is no, because it carries high cardiovascular risk, high malignancy risk, and risk of dying from some other illnesses like dengue. Then you can't donate your liver or portion of your liver to a loved one. And sometimes find it difficult to obtain a life insurance. But also they also should be screened every 2 to 3 years for features of progression. This paper says that non-alcoholic fatty liver disease is associated with worse forms of dengue. That's probably these livers do not tolerate ischemia well. And if you want to obtain life insurance with a fatty liver, you find it difficult. They want to increase the premium. And this was known to the insurance industry for many decades, maybe even before the doctors realized how important it is. So if you have a raised ALT, what does it mean? Does it matter? Because most of us may be having raised ALT level. So what's the normal ALT level? Now we consider it to be around 30 for a man and 19 for a female. 40 is maybe high for twice as high of the normal for a female. So what does it mean? If you have elevated ALT, it increases all-cause mortality, increases liver-related mortality. So if you have a raised ALT, your chance of dying is more. This is fatty liver. This is a normal liver, which can lead to a fatty liver, then fibrosis, cirrhosis, and ending up with terminal failure and maybe a hepatocellular carcinoma. This process happens over many decades. If you have a normal life in your childhood, say if you have a fatty liver after start eating fast food or whatever in your 20s, then you can end up with liver cancer at the age of 50 or 60 years. So take at least a decade to progress from one stage to the other. And also it gives us some time, some space to act in between, intervene, and to delay progress from a stage to the next stage. So what contributes to the progressive illness? Insulin resistance, adipose tissue dysfunction, genetics and epigenetics, and issues with the gut microbiome. At the same time, NAFLD is a multi-system disease because it affects the extrahepatic organs as well. It's very well known that it associated with diabetes, heart disease, CKD, hypertension, malignancies, polycystic ovary syndrome, and polycythemia. And majority of these patients die from cardiovascular illnesses. So it's so much associated with metabolic disease, changing the name to metabolic associated fatty liver disease is being debated. What's the liver-related mortality? Liver-related mortality is there only in progressive form of the illness. So 90% of us with fatty liver will not die from cirrhosis. And the single most predictor of liver mortality is the stage of fibrosis, not the ALT level, not the ultrasound scan grade. So what are the clinical predictors of fibrosis? Age. If you are middle age, if you have diabetes, if you are female after the menopause, and if you have obesity and other component of the metabolic syndrome, and if you have a family history or at high risk of developing the progressive form of the disease. So when you have the progressive form, even in the United States, they just end up with some form of a complication and present. So in between, usually you are not diagnosed and the patient will not know that he has ongoing fibrosis till they present with an episode of decompensation like hematemesis or even with the hepatocellular carcinoma. So NAFLD is a silent killer. So we have to, if you want to intervene, we have to diagnose fibrosis, preferably non-invasively. So what are the non-invasive methods of diagnosing fibrosis? There are very simple serological markers like the FIB4 score and the imaging modalities like FibroScan. So this is the FIB4 score, first published in 2006 and took about 14-15 years for us to realize that it's so valuable and reliable to be used in primary care. It just what we need is the age, the AST level, the platelet count, and the ALT level. And it's available as a free app online from a smartphone. You can download it, and it can be used as a bedside test. So if the FIB4 score is less than 1.45, value changes, maybe for South Asians, maybe lower, maybe 1, you can safely rule out advanced fibrosis at the primary care level. So I will give you a few examples of how to use, and if you don't use this, if you see a patient with fatty liver, you are not doing the justice to the patient nowadays. You should be familiar with the FIB4 score. It says young man with a ALT of 80, AST of 40, and the normal platelets. FIB4 would be 0.56, and you can safely rule out fibrosis, and you can repeat the non-invasive markers in 2 to 3 years. Another example, now here is older, AST has gone up, platelets have come down. These are very subtle changes, will not be picked up by the ultrasound scan or if you just do the AST. So FIB4 is 2.17. This is advanced fibrosis, and this patient needs a FibroScan. This is example of cirrhosis, AST, ALT completely reversed and platelet counts low, and FIB4 is 7.87. This is cirrhosis, and this is a patient with normal liver enzymes. So within 40, both AST and ALT, but still FIB4 picks up the fibrosis, and the FIB4 is 3.39. So this is also early cirrhosis. So this is the FibroScan, which will tell you whether there is advanced fibrosis or not. And this is a couple of reports of from the FibroScan, 2 patients. Here they will give 2 values, the CAP score and the liver stiffness measurement. In the first patient, CAP is 204. That's the amount of fat, and 3.5 is the liver stiffness in kilopascals, which is normal. And if the stiffness is less than 8, we consider it to be normal. In the second patient, CAP is 209, slightly higher. And the stiffness is 33.3, that is advanced cirrhosis. Now this scale will give you, starting from 2.5 in a child, liver stiffness in kilopascals, to 75 in a patient who is dying from cirrhosis. And if it is more than 8, we consider it to be advanced fibrosis, and 12.5, if it's more than 12.5, it is cirrhosis. Now, what is the latest is the FAST score, which incorporates both the FibroScan and the AST level, which is considered to be more reliable. The paper was out this year, but still not come to the guidelines. Unfortunately, you need the fibroscan here, but for the entire country, we have only 2 fibroscans. I don't think it's going to be very useful for us in the near future. So this is algorithm. All of you should know this. This is approved by almost all the guidelines. At the primary care level, you can use the FIB4 score and safely rule out fibrosis if if the FIB4 score is more than 1.3, then the patient needs a fibroscan. Then after doing the fibroscan, if the patient liver stiffness is less than 8, then it is low risk and you can start the lifestyle modification. And the liver stiffness is more than 8 kilopascals, then the patient needs a liver biopsy and liver-directed therapy. I will come to that later. So if you consider therapeutics of NAFLD in 2020, still we rely mainly on non-pharmacological methods, but there is a lot of progress in the pharmacological methods as well. So non-pharmacological weight reduction of 7 to 10%. Diet, I will come to that in detail. Predominantly, we need a calorie deficit and exercise. So this is the landmark study by Villa Gomez 5 years ago, which showed that if you can achieve more than 10% weight loss, there are going to be reversal of the fibrosis. In the morning, we heard that if there is 15% weight loss in newly diagnosed diabetics type 2, there is going to be reversal of fibrosis. So weight loss is becoming a key component in managing these patients. If you lose more than 5% of the weight, there will be significant improvement in the histology, including NAS resolution if you lose more than 7%. So this study, what did they do? They wanted the patient to be on a 750 kilocalorie deficit every day and 200 minutes of brisk walking for the day, at least five times a week. And they continued this regime for 1 whole year. But unfortunately, with the strictest of protocol, only 30% achieved a weight loss of more than 5%. So why it is so difficult to lose weight? Obesity is a complex neuropsychological disease, and we need very specialized weight reducing program. It's a science to reduce weight, and we need very specialized weight reducing programs to reduce weight. Can we use bariatric surgery? Bariatric surgery with weight reduction improves all forms of histology in NASH, but unfortunately at the moment it is only recommended if other indications for bariatric surgery are present, like in Asians, if the BMI is more than 35 or BMI more than 30 with comorbidities. And the laparoscopic sleeve gastrectomy is the most popular surgery, and you are going to listen to more about it, I think, tomorrow. What about the diet? It is not a fat-free diet. You can use monounsaturated fatty acid. It's low in saturated fat and processed meat, low calorie, low refined sugar, low added fructose, low in fast foods, high in cereals, grains, fish, poultry. So what is recommended is either a DASH diet or Mediterranean diet. So DASH diet is the dietary approaches to stop hypertension diet. I think we need adaptations of these diet plans to Sri Lanka. And I think dietitians should play a major role looking after these patients with this adaptation to Sri Lankan culture. Then I would like to talk a bit about fructose. Fructose is a major component of table sugar and many added sugar syrup. So children, when they get excessive fructose consumption, it can lead to addictive behavior called fructoholism, and it can lead to fructoholic liver disease, just like alcohol and alcoholic liver disease. I think we are going to get epidemic of fructoholic liver disease. We may be already seeing that epidemic now. So children should not be getting added sugars, and the parents have to be very careful about it. You have to stop cigarette smoking completely. There's evidence for that. And start drinking coffee, because there's evidence for that as well. Coffee is beneficial in NAFLD, coffee is beneficial in cirrhosis, and also reduces the incidence of liver cancer. Exercise, beneficial. Every form of exercise, moderate exercise to vigorous exercise to resistant training, all methods are beneficial, and the recommendation is just do it. Alcohol, there is no data on this. Better to avoid alcohol totally. And what about a little bit on lean NAFLD? If someone has normal weight, normal BMI, what can we do? Can we ask them to reduce the weight? This is probably genetics and maybe gut microbiome playing a major role. And lean NAFLD also is progressive and maybe carrying a worse prognosis if they have the genes. So the same treatment options with exercise and dietary manipulations and some degree of weight loss, we can't ask them to reduce 10% of their weight. So what are the pharmacological therapies available? So this is only for patients with advanced fibrosis. So not all people with NAFLD need pharmacological interventions. Only about 10% of the patients will have advanced fibrosis, and the pharmacological interventions are reserved for patients with advanced fibrosis. So what are the drugs available? Vitamin E, pioglitazone, saroglitazar, GLP-1 agonists, and obeticholic acid. I will take one by one. PIVENS trial, the landmark trial 10 years ago by Professor Sanyal, showed that vitamin E and pioglitazone were beneficial, and this was done in a population who didn't have diabetes. But so a lot of, maybe 70% of our patients with advanced fibrosis have diabetes. So what can we do? So maybe pioglitazone, because from recent studies, it shows that pioglitazone is effective in patients with diabetes and pre-diabetes. Most of the issues with pioglitazone have been sorted out, except for the fact that it causes weight gain and ankle edema in 10% of the patients. So what is recommended is to start pioglitazone with a smaller dose and see whether the patient develops ankle edema or weight gain. And in 90% of the people, we should be able to continue if they do not develop ankle edema or weight gain. And this is Professor Yunusi presenting the data on obeticholic acid last year. Obeticholic acid is a drug brought up by the pharma industry. And in the interim, it's a 5-year study, but interim analysis was done last year. And it showed that there is improvement of the fibrosis in 38% of the people. And this is the only drug that have been shown to be beneficial as far as the fibrosis is concerned. But unfortunately, FDA rejected the fast track application for approval this year, citing side effects. So at the moment, there is no FDA approved drug. Only drug that has been approved for NASH in the world is saroglitazide, something like pioglitazone. Saroglitazide is approved in India. What about the new kid on the block, SGLT2 inhibitor? So in the morning, we heard that it's brilliant for the heart, it's brilliant for the kidney and so on. Now, if it is brilliant for the heart and the kidney, it should be brilliant for the liver as well. So from the meta-analysis, from the few studies that we have, it has shown promise. We really do not know whether it has a specific effect on the liver or is just the effect on the weight reduction that it brings on. So whatever it is, looks very promising, and already there are meta-analysis on its use in fatty liver. but still not recommended anywhere in the world. So might as well use it if the patient is obese, and if you want weight reduction and diabetes control, might as well use it. Then to statins, statins remarkably safe in liver disease and should be used if indication. No way you should not be using statins just because the ALT is elevated. So if you diagnose NASH, I think you have to use statin if indicated. Especially most these patients with advanced fibrosis being diabetics, you always find an indication and started statin in this patient. So this is what's happening with statins in liver disease. So it's coming up as a kind of a treatment option for advanced liver disease, that's cirrhosis, preventing hepatocellular carcinoma, delaying fibrosis, like the role played by carvedilol and captopril liver failure, sorry, heart failure. So it has so many effects like uh, reducing inflammation, reducing oxidative stress, reducing angiogenesis, and probably reducing the incidence of hepatocellular carcinoma and cirrhosis. So if you have indications for use of a statin in a patient who has got already got cirrhosis, please use a statin in these patients. To summarize, Chairman Sir and Madam and ladies and gentlemen, progressive NAFLD is mostly food related. Gut microbiome, all brought on by probably bad eating habits, fast foods and all, and genetics play a major role. Fibrosis stage predicts survival, and the fibrosis stage can be reliably diagnosed non-invasively now without a biopsy. Lifestyle modification is the key. 10% weight reduction reverses fibrosis, but only few can achieve it. Comorbidities should be carefully taken care of because it's not the liver disease which has a higher mortality, it's the heart disease. And also, if the patient needs a liver transplant in the future, the heart and the kidneys should be in good uh, stage to for him to undergo the liver transplant, which is a very difficult operation. Pharmacological breakthrough is awaited. Still, we don't have a perfect drug. Available options reserved for patients with advanced fibrosis. Statins have a role to play, but appears underused. Uh, just a note at the end. Now, these are migratory birds. Just before their departure back home, they start feeding profusely. Within days, they have their livers enlarged with fat up to 10 times the normal. And then they fly back home non-stop 7 to 10 days using that fat as the energy. So at least in birds, you can get a fatty liver fairly quickly, and also you can get rid of the fat fairly quickly. That's the lesson that we have from the birds. So thank you very much, ladies and gentlemen, for your kind attention.
Thank you, Professor Dasanayake, for your very informative lecture. So now we are left with 5 minutes for the questions. We got one question from one of our audience. You mentioned GLP-1, but any hopes or evidence?
Yes, there are two trials. One for can't remember the name. There are two trials already. One small study with 25 patients, and another large study with 200 patients, biopsy proven, but still it's injectable. So because of that, only both studies are phase 2. So to be recommended, you need larger phase 3 trials. So probably we'll have a phase 3 trial soon, and they reduce the weight as well. So it's going to be, beneficial in the long term because the weight loss. Yeah.
I ask one question. Yeah. There's a new nomenclature, MAFLD, instead of NAFLD. How does?
Yeah, it was described by Madhuli in the morning.
Yes. How does it?
Yeah, there's still a debate. So a lot of people are for that, and there are equal amount of hepatologists who are against that as well, because sometimes what they say is sometimes it's genetic. Sometimes it is drug induced. So majority are related to metabolic syndrome. No firm decision has been taken as yet, but it takes some time. There's a huge debate going on whether should be name should be changed to NAFLD or MAFLD from NAFLD. Yeah.
Thank you very much. So shall I ask my co-chair, Dr. Suranga Manilagama, to give away the token of appreciation to Professor Dasanayake.
Let me introduce the second speaker of the symposium. He joined with us virtually. So let me introduce Professor Andrew Goddard, President, Royal College of Physicians. Over to you, Professor Goddard.
Hello, I'm Andrew Goddard. I'm President of the Royal College of Physicians, but I'm going to talk to you today about inflammatory bowel disease, which is what I am a specialist in Derby in the United Kingdom. Inflammatory bowel disease is a huge area, and I'm going to try and focus on some of the new emerging thoughts about IBD, but also how perhaps IBD in Sri Lanka is different from IBD in the UK and other parts of Europe. I would assume that most of the audience has a reasonable idea about inflammatory bowel disease, but just to refresh people, we're talking here about Crohn's disease and ulcerative colitis, and a group of people and patients in the middle of this who have what we call indeterminate colitis, whereas we're not sure which of those two different diseases it is, but often with time it becomes clearer. Crohn's disease, of course, can affect anywhere in the gut from the mouth down to the anus, whereas ulcerative colitis is almost always involving the rectum and colon proximally. So first thing to talk about with IBD is its cause, and this is a topic of much debate, and this slide sort of shows the 5 overlapping areas that are probably important in the pathogenesis of inflammatory bowel disease. About 25% of IBD is heritable, and we're beginning to understand more and more about which bits of the genome are important for this. It's been known for decades that there are families who have inflammatory bowel disease and are at increased risk of it, and the links perhaps for Crohn's disease are stronger than they are for ulcerative colitis. Interestingly, within the UK population, they often change between different generations, and I've got several families where one generation have UC, the next generation have Crohn's, and then the following generation have UC, for example. The ability of GWAS, so genome-wide association studies, to look at the whole of the genome and correlate that with clinical findings has allowed 201 at the last count different loci for IBD to be identified. Interestingly, over 80% of these are non-coding, and that brings in the whole idea about epigenetics. And this may well be that the environmental factors such as smoking come into play, and how they sort of affect expression of the genes. And the expression of the genes is really important. I'm going to come on to that, and I'm going to talk about sort of transcription as an important thing within IBD pathogenesis. Most of those genes seem to be related to the immune response. We know there's a close overlap with other autoimmune diseases with IBD, but the NOD2 gene, and I'll talk a little bit about that, was the first clear sort of, if you like, genetic predisposition marker that was identified back in 2001, and for patients with Crohn's disease and aggressive Crohn's disease, 20% of that can be predicted through NOD2 mutations. But other parts of the immune signal, including IL-23 signaling, have been shown to be important. So the current theory is that in people who have a genetic predisposition, there is an environmental factor including smoking, diet, and medication, which then has an effect on damage to the mucosal barrier, and then the interaction of the microbiome within the lumen of the gut results in an establishment of an inflammatory process, and you get IBD. There's no doubt that the microbiome in patients with IBD is different from control patients, and we're beginning to understand more about the relevance of the microbiome in IBD. The things that can damage the mucosal barrier include smoking, but particularly medications such as NSAIDs do seem to be important. But all of these 5 factors interact, and there isn't a single cause, if you like, of IBD. So one of the interesting things that people are talking a lot about at the moment is autophagy. So autophagy is, if you like, self-cannibalism of cells. It's the process is whereby when things are under stress, the cell recycles parts of itself in order to be fitter and more ready. And that includes bacterial contents. So in NOD2 mutations, and NOD2, the gene relates to intracellular pattern recognition. In those mutations, then sort of autophagy does not work as well. So the cell is less able to handle the bacteria and understand what's happening with those bacteria. And you get a change in relation between the bacteria in the gut lumen and the immune cells around it. Now, within Sri Lanka, people have looked at this. There's already been well established within Asian populations that TNF mutations are important. But this study that was published in 2018 looked at 16 different single nucleotide polymorphisms, which are well recognized within the Western population to be associated with inflammatory bowel disease, whether there was any correlation within the Sri Lankan population. And the ones I've highlighted in red are where they did find there was a correlation and then it increased the risk, and the one in green where it reduced the risk. So you can see that for most of those, then there was not a association with those SNPs and IBD in the Sri Lankan population. And that gives us a clue that the sort of like the genetic components of IBD in the Sri Lankan population are different from other parts of the world. And that's probably true throughout the world, that different populations have different risk factors. So the SNP looking at IL-12 does seem to increase your risk of having upper GI Crohn's disease, which is pretty rare in the Western population. But for example, LAM1, which increases the likelihood of having mild UC as opposed to severe UC, and then once you have remission, keeping it there is recognised. That might explain why ulcerative colitis in the Sri Lankan population seems to be a slightly milder disease. So people have been thinking about the genomics of IBD for a while, and first question is, can we predict who's going to get IBD? And with all those SNPs, you can start to come up with a polygenic risk score. If you with these genome-wide analyses now, can you take a patient and say, well, we can predict what you're likely to get from IBD? The problem with that is that there are 2 overlapping populations, and that's expressed in the top graph here. So one population is those without IBD in the orange, and in the red, in the purple are those with IBD, and you can see there's a huge overlap. So having an individual polygenic risk score isn't particularly helpful, except at the absolute extremes. And I think that whilst this was an area for fertile study at the beginning of the analysis of the genome in relation to IBD, we're now sort of moving away from thinking about risk for getting IBD and more to do with what happens if you have IBD. What is the disease going to do? What's your prognosis? And this is the developing field within IBD. Are you going to have a very mild disease that's not going to develop much and you can treat with relatively safe medications, or you like to have a very aggressive disease prognosis that you need to treat aggressively from the outset? So you can look at that from the point of view the genetics itself, but also then how those genes are expressed, and that's where transcriptional profiling is important. And this is all being developed, and this is the sort of the as I said, the hot area in IBD, and hopefully we'll soon come up with some tools that will allow us, with a patient with inflammatory bowel disease, to let them know what the chances are this is going to be a well-behaved case of IBD, or one that we need to jump on quite aggressively. Serological tests remain a bit of a challenge, but that is sort of also being looked at as part of all of this. So, as I say, you can look at risk. So very early onset IBD behaves very differently, and there do seem to be families and close genetic links to that. So that's one group that you would look at. You say you can come up with a polygenic risk score, but it's not particularly helpful. Disease progression, as I've just talked about, is important. But then, how are they going to respond to disease? We know that in the whole of medicine, that we treat many people with drugs that will never work for them because of their genetic makeup. And I think that as time goes on, in 50 years' time, people will look back on how we managed our patients to say how primitive it was that we never sort of assessed their genome and used the drugs that suggested would work for them. I think the thing that is most relevant for this whole area of pharmacogenomics, if you like, which is about to do with treatment response and adverse events, is the ability to predict who is going to run into trouble with these drugs, particularly with the thiopurines that we use in IBD, but also with the biologics. So if you like, those are the four areas that we think about when we're looking at molecular profiling. So to come back to the idea of what is happening in IBD, if you take a normal bowel, which you can see on the left-hand side of the slide here, you have bacteria, the microbiome within the gut lumen, and interacting through their products with the epithelial layer. That is detected within the dendritic cells and sort of then communicated with the immune system. In IBD, you get a damage to the mucus layer and the tight junctions between the cells, so there's a change in the signaling, and you then get activation of the macrophages, including a response that I've talked about of autophagy, and that then upregulates the immune system to encourage the inflammatory cells to move outside of the blood vessels, so through things called integrins, where they adhere and then migrate through the endothelial layer, and you get an escalation of the immune response, which is what IBD is. So with all of that rather complex background, what is the difference between IBD in Sri Lanka and the UK? So clearly it's much less common, and for ulcerative colitis, which I consider first, probably about 100 times less. There aren't much differences. It's pretty equal in men and women, and there isn't really much evidence with UC about socioeconomic gradients. As you can see from the extent, it does seem to be less extensive in Sri Lanka, and the disease seems to behave in a much more mild fashion. So we would expect over a 20-year period in the UK that about 10 to 15% of people with ulcerative colitis will end up with a colectomy, whereas in Sri Lanka, from prospective and retrospective studies, that looks to be about 2 to 3%. Cancer risk is also lower, which probably goes along with the mildness. We think a lot to do with cancer risk in patients with ulcerative colitis is due to prolonged inflammation. So if you have a milder disease or a more limited disease, your chance of getting cancer is much less. 6% of people in Sri Lanka with patients with IBD use biologics. In the UK, it's quite hard to get that data, but it's probably in the order of 20% at the moment. For Crohn's disease, again, it's even less common than ulcerative colitis, and certainly compared to the UK. Interestingly, Crohn's disease is more common in women in the UK, but it's more common in men in Sri Lanka. We don't have a good reason or understanding why that is. There doesn't seem to be a socioeconomic gradient for Crohn's disease in Sri Lanka, whereas there is within the UK. But that may simply be that we haven't identified some of the cases in the poorest parts of the community within Sri Lanka. And I think there's more work to be done there from my reading of the literature. Crohn's disease in Sri Lanka is a predominantly colonic disease, whereas in the UK it's much more small bowel related. And you are using biologics in a quarter of your patients, and we are using them a bit more than that. And that's what I want to focus on now. Just to say, just before I get onto that, is that the prevalence of all types of IBD in the UK and in Europe and the Western world is increasing steadily. And we're seeing this in our clinics and the demand that we're getting, and you are now seeing that in Sri Lanka. And I think there are all sorts of arguments about lifestyle and the environmental risk factors that we've talked about that predispose to IBD, and I think you are now seeing that in Sri Lanka. This is the college, and I put this up to talk about steps up and steps down treatment. So trying to decide how you manage IBD, you want to, in some patients, use the safer but less effective treatments first, and then move on to the highly effective but expensive and potentially riskier treatments later, and that's sort of step up. Some people, for certain types of aggressive disease, the evidence is that you should treat them with the more expensive but effective and perhaps less safe biologics first up. And you can use genomics, just to come back to the genomics line, you can use genomics to predict which you should use. And I've sort of talked about that, so I won't dwell on that. I just wanted to say that the biologics that we're using are used in many different medical conditions, and not just inflammatory bowel disease, but dermatological conditions, rheumatology, and other immune. There's a huge crossover. But some biologics that work well in IBD don't work in other non-IBD immune-regulated conditions, and vice versa. So we are learning more and more. We've always, as gastroenterology, been a bit behind rheumatology. They tended to be ahead of the field when it comes to biologics. But many of the drugs, such as etanercept, that have been used for years in rheumatology, don't actually work for IBD. So the main drugs that we use are the anti-TNF biologics, infliximab, adalimumab, and golimumab. These, as you can see on the left-hand side of them, sort of work on the TNF receptors, either to mop up TNF within the plasma, or actually to stop TNF binding to those receptors. And that then down-regulates the immune response. The other class of drugs are those that are acting via the JAK-STAT pathway through the IL-12/23 receptor. And ustekinumab is the biologic that does that by binding to the P19 IL-23 P40 subunit. And tofacitinib works intracellularly. Tofacitinib is particularly interesting because it is an oral medication, which is the first sort of immune regulator biologic type drug that we're able to give orally, and we're using it more and more for UC. In my last couple of slides, I wanted just to summarize the effectiveness of biologics in ulcerative colitis. This is really hard to get good data because there are so many trials out there, and I can't find one single source that sort of summarizes it all on one slide. So I tried to do it here. I tried to give summarize the trials that are out there for each of the different drugs. So you can see infliximab, adalimumab, golimumab, vedolizumab, tofacitinib, and ustekinumab along the bottom, and then the blue line shows you the percent remission from ulcerative colitis and those that show a response. And whilst these are very useful drugs in patients that have very troubling symptoms, I think what you can take here from here is they are not absolute miracles. They have revolutionized individual patients' life. I have no doubt about that. And particularly for Crohn's disease, what we now see in hospitals, in our outpatient clinics, but on the wards, has been revolutionized by biologic treatment. But you have to tell patients that the chance of this putting somebody into remission for most of these drugs is around 1 in 4. And whilst most of them will get an improvement in symptoms, probably, you know, a third of them won't. And we are now, so you try one biologic and you move on to the next. So they are great drugs, but they are not, you know, brilliant drugs, if I can put it like that. For Crohn's disease, I think the results are slightly better. And the second bar there, infliximab and azathioprine, there's no doubt the combination of infliximab and the thiopurine azathioprine is much better than either agent on its own. So we will try and use combination. Vedolizumab is a relatively new drug, as is ustekinumab, and we are learning more and more about it. But you know, your response to biologics in Crohn's disease seems to be better, if I just go to it, than in ulcerative colitis. So hopefully that's sort of an overview of thousands and thousands of patients that have been involved in various biologic trials in IBD. That sort of gives you an overall sense of how effective they are. So I will stop there, and we will come on to questions, and I look forward to answering them. Thank you for listening.
Thank you, Professor Goddard. I have a question for you. So you mentioned that there's a difference between the prevalence of the disease in UK and Sri Lanka. So what do you think? What is the reason behind that?
Hi, I hope you can hear me. I think no one knows is the blunt answer to that. I think undoubtedly it's going to be a bit to do with the genetics, which is why I sort of spent some time talking about that. But clearly also it's going to be the risk factors that the different populations are exposed to. The microbiome in different parts of the world is very, very different. It's a lot based on what you eat as well as your genetics. So I think we're going to struggle to tease it out. I think what the interesting thing is that for many of these diseases, they are increasing as populations become more westernized, if I can use that phrase. And certainly there was a lot of interest 10 years ago in the hygiene hypothesis in Crohn's disease, and the feeling that, you know, children that were exposed to a lot of different infections earlier in life sort of built up more of a T1 response, and they were less likely to get Crohn's disease. And that might be one of the explanations as to when you first get your gut infections defines how you handle gut infections and the microbiome as you move through life.
And there's another question for you. So you described nicely the role of the microbiome with the occurrence of the disease. So are there any new treatment options to alter the microbiome to treat IBD?
We've known for a long, long time that for Crohn's disease, if you change the diet and you move to a so-called elemental diet, that you can get as good a treatment effect as you might do for steroids. And that's used in children to stop them having to be exposed to steroids and the effects that would have on their growth. So there's no doubt that if you adjust the diet of somebody, you'll make a difference. And the other sort of contributing bit of evidence to that is fecal diversion. And we know in patients that got, for example, perianal disease or colonic disease, that if you give them a stoma and you divert the fecal flow away from that bit of that, it will, in general, calm things down considerably. So that sort of shows that it's what is passing that bit of gut, the microbiome within that bit of gut, which is critical. You can heavily influence your microbiome by what you eat. And again, that's why I come back to that. And that might explain a lot of the differences between different parts of the world when it comes to prevalence.
Time is up. Thank you very much, Professor Goddard. And thank you for your interesting lecture. And we'll hope to see you next year as an in-person to our next sessions, 2021.
I hope that truly too, and I'm really hoping to be there next year, and I look forward to be able to shake all your hands in person.
Okay, thank you very much.
Yes, our last speaker is Dr. Nilesh Fernandes-Pulle. It's my great pleasure to introduce Dr. Fernandes-Pulle. to this audience, my colleague. He's going to speak to us on what is new in other colitis.
Okay, thank you, Lasantha. I would like to thank the College of Physicians for inviting me to give this talk. And I'm actually happy that my talk was preceded by a talk on inflammatory bowel disease, because when we generally talk about colitis, what comes to our mind is generally IBD. That is probably because IBD has taken this general term of inflammatory bowel disease. So anything related, any symptoms related to inflammatory symptoms related to colon or even on colonoscopy generally gets labeled as IBD. But in real life, it's not so. And actually, there are lots of other colitis which are treatable, which should be recognized and treatable and treated differently. So I thought in this limited time, I'll take 3 of those different types of colitis and try to describe them to you. So to begin with, I'll start with a short case scenario of each of those three types of colitis. First case is 70-year-old woman with a hypothyroidism history, presents to the casualty with acute onset crampy abdominal pain, followed by 6 to 8 episodes of loose stools mixed with bright red blood. Examination is basically normal and labs are normal. So what is the next best step in a management? You would do a C. diff testing, antibiotics, a CT scan, CT angiogram, or a colonoscopy. I'll just leave it at that. I'm not going to give you the exact answer here, but this is generally I would say a typical history of ischemic colitis, or what you call colon ischemia, where you get acute arterial occlusion or venous thrombosis, or sometimes due to hyperperfusion of the mesenteric vasculature, where you get ischemia in the colon. There are 2 types. One is type 1, which is seen in the majority of cases, where it's a non-occlusive small vessel disease, where there is no specific treatment, and generally it's broadly a supportive treatment that we need to do. Type 2, where you get more of an identifiable cause, which can be due to hypertension, maybe decreased cardiac output, maybe even after some cardiac surgery, where you need to find the cause and probably treat the underlying cause. What are the risk factors? Here it's very interesting, because when we think of ischemia, what comes to our mind is thrombosis, thromboembolic diseases, or things which cause basic atherogenesis. But in ischemic colitis, actually, things like diarrhea, constipation, certain drugs like constipation-inducing drugs, and even illicit drugs like cocaine, which is getting quite prevalent in Sri Lanka, is known to cause ischemic colitis. And even extreme exercise. It's known that endurance athletes, after they run a marathon, they come with severe abdominal pain followed by diarrhea. Actually, I've seen 2 patients in Sri Lanka. So it's actually the history that gives the diagnosis there. So the risk factors are very important. What are the clinical features? Like I just explained in the clinical scenario, they come with abdominal pain, which can be mild to moderate. And there's this urgent need to defecate, which occurs within about 24 hours, which is associated with bloody diarrhea. In the left-sided disease, it's more blood. In the right-sided disease, where what you call isolated right colonic ischemia, they actually have more pain. Generally, the outcomes are quite benign. That's probably why we miss it also. And it's self-limited, unless it's in the right colon, where the mortality is more. Gangrene is seen about 20%, fulminant colitis probably little less, about 2.25%. And recurrence rates also quite low, about 10%. What are the labs that we need to do? Basic full blood count, CRP, albumin, amylase, CPK, lactate, and LDH. These are not specific for colon ischemia, but any abnormality in this, with your clinical suspicion, we'll be able to catch the diagnosis. And a lot of times, because it's a short history, we need to think of infections. So stools, cultures, and C. diff tests are probably indicated. Remember, routine coagulation studies are not indicated in these patients, unless it's a young patient or somebody who comes with recurrent colon ischemia. What is the test that we need to do? Imaging-wise, CT, IV oral contrast is the imaging test, investigation of choice, where I would see bowel wall thickening, edema, and thumb printing. If you see a bit of pneumatosis or portomesenteric venous gas, that's probably indicating quite severe disease where there's transmural involvement. Vascular imaging studies are not indicated in all the patients, although we are thinking of thrombosis, because they don't usually correlate with disease. And if you have to do vascular studies like CT angiograms, usually it's done only in patients with right-sided disease, or if they have suspected acute mesenteric ischemia. They come with severe abdominal pain and the ischemia keeps on going on, so you need to do something for them. What's the place of colonoscopy? Colonoscopy is generally adjunct to CT abdomen. It's usually done early if you're doing it with very careful minimal insufflation, but make sure you avoid it in severe disease. So like I told you, you do the CT to find the extent and colonoscopy to probably give you the diagnosis, because endoscopically also you can suspect it. And you would biopsy the colon if you do not have gangrene. I know this is the management of colon ischemia. I know it's a very crowded slide, but I just kept it there. But I'll give you a summary and gist of it. So basically, you do a clinical assessment, do the history taking, do the clinical examination, and do a few bloods. And you try to categorize them into mild, moderate, or severe disease. Mild disease would be generally a patient who's clinically stable, hemodynamics are okay, bloods are generally okay, patient is kind of a stable patient. The severe disease is the opposite spectrum, where you get a very severe toxic patient, clinically ill-looking, bloods abnormal, features of peritonitis. Okay, so you get the two spectrums, and probably the moderate disease comes in between there. For mild disease, generally they are quite asymptomatic, like I told you. It just needs a bit of supportive treatment. Severe disease, you need to refer them to a surgeon, because very likely those patients will need surgery. Moderate disease, it's again supportive treatment, but you probably need to give them bowel rest, IV antibiotics, and some IV fluids. So that's basically a gist of management of colon ischemia. So what are the take-home points? It's a common and benign disease. Isolated right colon disease is the more severe disease. CT abdomen and pelvis with IV contrast is the investigator of choice. Colonoscopy is adjunct to CT, should not be done by itself, especially in the acute setting. Antibiotics should be used in moderate to severe disease, and you need to speak to your surgical colleagues if you're dealing with severe disease. Case number 2, 60-year-old woman referred to your clinic with 6 months history of diarrhea, 4 to 7 times of bowel movements a day, loose, non-bloody, no abdominal pain or loss of weight. She has been taking over-the-counter antidiarrheal drugs to control her symptoms, but with few accidents in between. No major medical history, but she's on sertraline for some psychiatric symptoms. Bloods are normal. Again, what would be the next workup? Do the hydrogen breath test, upper endoscopies, flexible sigmoidoscopy and biopsy, colonoscopy and biopsy, or a CT angiogram. Again, these are kind of a typical history of microscopic colitis, where there are two types called collagenous colitis and lymphocytic colitis. They typically come with watery diarrhea, and they can also have some abdominal pain, weight loss, and arthralgia. Typically occurs in older females, above 50 years, and also typically associated with lots of drugs, which I'll give you the list later. And labs are negative, and importantly, the stool calprotectin is not very useful in these patients. There are factors which might predispose you to make or suspect this patient to be having watery diarrhea patient to having microscopic colitis, older patient, nocturnal symptoms, maybe some weight loss, introduction of new drugs, and autoimmune disease. What are these drugs? PPIs, NSAIDs, H2 receptor blockers, SSRIs are the high culprits which cause microscopic colitis. And the other ones are carbamazepine, lisinopril, and statins. So if any patient you see coming with water diarrhea with these drugs, always suspect that this patient could be having microscopic colitis. How do you diagnose it? All those patients, unfortunately, need a colonoscopy. And the colonoscopy is going to be macroscopically normal, but you need to biopsy. And if you're actually a person doing colonoscopy, make sure that you take biopsies, at least from 8 biopsies from different segments, because you can have patchy involvement. There are diagnostic histological patterns, which I'm not going to go in detail, but it's basically a histological diagnosis. Treatment, budesonide is a very good drug, best studied drug for microscopic colitis, has a good response of about 80%, but can relapse when you stop it. So you need to be on maintenance treatment on the lowest effective dose. If the patient does not respond, think of your diagnosis, where the diagnosis is wrong, especially things like bile acid malabsorption is possible, which we don't recognize much in Sri Lanka because we don't have the tests which is available to diagnose it. Make sure that you review your diagnosis with a pathologist, see whether the drug has been stopped, which is the culprit drug, see whether the patient is taking the drugs, or also evaluate for other cause of diarrhea. What are the treatment options? We can try prednisolone and bile acid binders, because bile acid malabsorption is a possible cause for patients who not respond. Immunosuppressants don't work too much well for microscopic colitis. So what are take-home messages? Any patient with watery diarrhea, especially older females, always think of microscopic colitis because it's a treatable condition. What are the drugs which are PPIs and SSRIs are the drugs which you need to think about. which cause microscopic colitis, and make sure that you take biopsies from the right and left colon. And bismuth and budesonide are the induction treatments, and budesonide for maintenance treatment. Case number 3, a 64-year-old man with prostate cancer undergoes radiotherapy 3 years ago and then presents with persistent rectal bleeding. Colonoscopy confirms a suspicion of chronic radiation proctitis. What are the treatment options that you would recommend? Is it antibiotics, steroid enemas, sucralfate enemas, mesalamine enemas, or oral mesalamine? I'll just again go through a bit of radiation proctitis. Again, it's common with external beam radiation rather than brachytherapy. Obviously, with the lower the radiation dose, the long-term side effects are less, but still about 1 to 5% of patients who get external radiation for pelvic malignancies would end up having chronic radiation proctitis. What are the clinical features? If it's acute, usually it's less than 6 weeks from the radiation treatment. It's direct mucosal damage, diarrhea, mucus, urgency, tenesmus, and the bleeding is less. But when it's chronic symptoms, which after 9 months, it can go on to up to 30 years, where there is progressive epithelial atrophy and fibrosis due to chronic mucosal ischemia, bleeding is one of the predominant symptoms. They can have bleeding, mucus, tenesmus, urgency, and incontinence, and even go on to develop strictures. And if the surrounding organs like the genitourinary tract are involved, they can have fistulas or have strictures causing obstruction or even bacterial overgrowth. I'll just stick to chronic radiation proctitis for this presentation. If you suspect a patient to be having radiation proctitis, always make sure that you exclude the primary malignancy has been, the recurrence of primary malignancy has been excluded. So that patient will eventually need an endoscopic evaluation and some biopsies. Radiation proctitis is generally an endoscopic diagnosis by itself. If you suspect fistulas, probably patient needs MRI, and if there is obstruction, you need a CT scan. What are the treatment options? There aren't many randomized trials for radiation proctitis, but you can use glucocorticoid enemas or hydrocortisone enemas, especially if the patient has tenesmus. Sucralfate enemas are probably the best the drug with the most amount of evidence to treat the bleeding of radiation proctitis, better than 5-ASAs or steroids. But the oral medicines like the oral 5-ASAs, metronidazole, pentoxifylline, have not much data. But if you manage to gain some sort of a control in those patients, the remission can be sustained after even discontinuation. There is also endoscopic treatment. If you can look at the picture on the top left, right-hand corner, those are basically, and like telangiectasias, where it's basically fragile blood vessels which are bleeding. And those can be quite effectively treated endoscopically by argon plasma coagulation. Or you can also use radiofrequency ablation, laser, and cryotherapy. So what are the take-home messages there? So about 1 to 5% of patients with external beam radiation for pelvic malignancies can develop chronic radiation proctitis. Sucralfate enemas are the first-line treatment for chronic radiation proctitis, and always consider endoscopic treatment with argon plasma coagulation, especially if the patient is persistently bleeding. Thank you. I think that's it.
Yes, we left with 10 minutes to ask questions. Questions from the audience?
Don't worry, it was very clear, I think.
There's one question. How often do you see microscopic colitis in Sri Lanka?
Yeah, so unfortunately, we don't have our data I don't have any data to support what I'm saying, but I would see about 4 to 5 patients maybe a year. 4 to 5 patients a year, if you do colonoscopies and take biopsies, or even probably more than that, maybe about 10 sometimes.
Okay, so Nilesh, usually what is the common sort of age group or the common sort of population they get microscopic?
The older people, older generation,
Older
and commonly
generation.
it's in females. So
Females.
any person over about 50 years come with chronic diarrhea, probably you need to suspect microscopic colitis, and unfortunately that patient will need to have a colonoscopy.
There is another question, Nilesh.
Just one more thing. So the diarrhea has to be just diarrhea only. It's not diarrhea and constipation alternating.
Alteration.
Lots of people you don't have to have colonoscopies if you have constipation, diarrhea, constipation. That's alternating symptoms, not for that. It's diarrhea, predominantly diarrhea only. So like
diarrhea.
IBS-D diarrhea type of patients.
Okay. So, how do you differentiate two types of microscopic cholangitis, microscopic colitis clinically?
It's very difficult. You can't. Some of the drugs probably cause, the PPIs probably cause collagenous colitis a bit more than others, but it's a histological diagnosis. It's at the moment, there is no difference in making a differentiate or distinction between the two diagnoses because the treatment is same.
What about formalin enemas in radiation proctitis?
So it was used before, but it's not used anymore for two reasons. One thing is very, very painful for the patient when you use it. Secondly, it also has been shown to induce malignancy. So it can cause neoplastic, not transformation, probably, yeah. So some sort of can induce rectal cancers. And it's very painful.
How is there is another one. How is the response to budesonide in Sri Lankan patients?
It's very good, but we don't have budesonide in Sri Lanka.
That's what I also was thinking when you were present in our
so we
area, we don't have budesonide.
We have
it's
to get
an
it down
oral
from
drug
outside.
that you are talking about.
Sorry?
The oral
oral budesonide, we have to get it from outside. Patients get it from India or Malaysia.
What is the tablet strength that you should, what's the dosage?
The tablet strength is 3 milligrams.
3 milligrams.
You start with 9 milligrams daily. And then every 6 weeks, you can tail off by 3 milligrams, you reduce it and come to the lowest possible dose.
Within how many period of time?
So every 6 weeks.
Every 6 weeks.
You reduce the dose every 6 weeks. And obviously, if the patient is getting a relapse, you might have to increase the dose. But generally, 3 to 6 milligrams, you can
maintenance.
Yeah. And budesonide has a very high first pass metabolism, so side effects also minimal.
Yeah. Can IBD and microscopic colitis overlap or evolve, or IBM later? Yeah. Can IBD and microscopic colitis overlap?
At the moment, there is no evidence to that.
Or evolve?
No. So there is no. That's the question. Yeah. There is no evolve from microscopic colitis to inflammatory bowel disease. No. Coexist. I don't know the answer to that actually. Possibly, I guess it could. I have not actually read about. I have not seen any patients like that. Sorry.
Okay. Is there a place for biologics in microscopic colitis?
No. There is very little place for immunosuppressants in microscopic colitis.
Okay. Can we give sucralfate oral as an alternative for radiation proctitis?
No. So the problem is it has to work locally. A lot of the treatments, even the 5-ASAs in IBD work locally. So when you take it orally, it has to go from the rectum or come out to the rectum to work. So that's why it's given enema. Again, Sri Lanka, we don't have sucralfate enemas. We have sucralfate oral syrup. So we can, in India, they have the enemas. So some patients get it down from India. What I do is we try giving the oral thing through rectally, but I don't know whether so whether it's very effective, I'm not sure. But enemas can be got from India.
Okay. There's another question, Nilesh. I'm tired.
Oh, go on.
How to differentiate ischemic colitis from diverticulitis from history?
Tell me again.
How to differentiate ischemic colitis from diverticulitis?
See?
Ischemic colitis from diverticulitis.
Diverticulitis?
Yeah.
Okay. So what I tell medical students, diverticulitis is like appendicitis.
They ask him from the history actually.
Yeah. So that's why it's like appendicitis. So you get like appendicitis, you get RIF pain. Diverticulitis, you get LIF pain. So it's fever, pain, those sort of symptoms. And constipation might be the trigger for the diverticulitis. So they might have a bit of constipation sometimes, but they don't have major bowel symptoms. It's pain, LIF pain and fever, and CRP will be high, WBC count will be high. Whereas ischemic colitis will be severe pain with urgency of need to defecate with blood within about 24 hours. I don't know where they are trying to, so diverticulosis is different, diverticulitis.
Yeah,
Okay?
diverticulitis.
So diverticulitis does not cause bleeding.
Yeah.
It's about diverticulosis causes bleeding. So those are two different things. So a lot of people confuse diverticulitis with bleeding from diverticulosis. Diverticulitis generally does not cause bleeding.
Any more questions? Yes. In the absence of further questions, let me conclude this symposium. Thank you, Dr. Fernand Fulle. Thank you very much, Nilesh. Shall I ask my co-chair?
I will invite my co-chair to hand over the token of appreciation to Nilesh. Thank you, everyone. This will come to the end of the symposium on gastroenterology, and so we have teaching capsules at we're starting at 5:30, and now it's wind up for the tea break. Thank you very much.